Welcome to the Ventilator and Pulmonary Mechanics Chalk Talk series, where we're learning how ventilators work and how to work with ventilators. I'm John McManigal. Let's get started. Over the last 3 lectures, we've covered all of the standard conventional ventilator modes, between pressure and volume control, pressure support, and the corresponding assist control and SIMV modes. You've got the majority of the ventilation happening in your intensive care units and operating rooms. We also looked at a couple of common modes that take advantage of modern computer-controlled ventilator valves. These include ramped volume control, which uses a decreasing flow ramp as its inspiratory limit, and pressure-regulated volume control, which changes its own inspiratory pressure limit in response to the detected tidal volume. But, as you might imagine, having computer-controlled ventilator valves and sensors opens a whole world of possibilities in terms of reactive or adaptive ventilator modes. We'll take a look at some more examples in this lecture. At least right now, you probably won't see these much outside of a medical intensive care unit, although they are starting to work their way into some home ventilators and advanced BiPAP machines. So if you skip this lecture, you won't miss out on any of the pulmonary physiology going forward. But if you're interested, here we go. We'll look at volume support, proportional assist ventilation, automatic tube compensation, and mandatory minute ventilation. We'll look at these as examples rather than diving super deep into any one, because every ventilator you come across will have slightly different advanced modes. So if you're going to use them, talk with the people working in your units and read the ventilator manual. Let's start with volume support, which is becoming more and more common, and is very similar to a mode called average volume assured pressure support in some BiPAP machines and outpatient ventilators. Volume support is, at its heart, a pressure support mode. So your breaths will be pressure limited breaths, and just like in pressure support, they're triggered by flow or by volume and cycled by flow. So the patient will start and stop their own breaths. What makes this mode different is that, just like in pressure-regulated volume control, as the patient's compliance or cooperation changes, the ventilator keeps track of the tidal volume achieved every breath, and then the computer increases or decreases the inspiratory pressure as necessary to maintain a target tidal volume. So, for example, on this first breath, the ventilator looks at the tidal volume and says, yes, that looks like what the operator set. On the next breath, compliance is decreased, so the ventilator sees the resulting tidal volume and says, oh, that's a little low, I'd better increase my inspiratory pressure. On the next breath, the tidal volume is on target again, so the ventilator sees a good tidal volume and keeps the inspiratory pressure the same. The same thing happens on the next breath, and then on the one after that, the compliance goes up a little bit, so the ventilator says, whoa, that tidal volume has gone up, so let's lower the inspiratory pressure, which it does again on the next breath. So you can think of volume support as a hybrid mode between pressure-regulated volume control on the one hand and pressure support on the other hand. You as the operator set a target tidal volume, and the ventilator computer will set its own inspiratory pressure to meet that tidal volume. The next mode we'll look at is called proportional assist ventilation. In this mode, the patient is allowed to breathe freely, and the ventilator supports their breathing effort by increasing the circuit pressure in proportion to how much the patient, using their own respiratory muscles, decreases their own pulmonary pressure to draw in air. The calculation that determines how high to raise the circuit pressure is complicated based on a lot of modeling and computed by the ventilator many, many times per second. The result is that the ventilator is taking on some proportion of the work of respiration. So what you as the operator set in this ventilator mode is the percentage of effort that you'd like the ventilator to take on. Generally, you start at about 80% and adjust from there. This one is becoming more popular in medical intensive care units because it minimizes the work of the breathing muscles, preventing them from fatiguing over long intubation periods. It's very comfortable for patients. If the patient tries to take a big deep breath, they get lots of support, and if the patient tries to take a smaller breath, they get a little less support. And when it's time to wean from the ventilator, you can do so just by decreasing the amount of respiratory effort being done by the ventilator as compared to the patient. Next, let's look at automatic tube compensation. In this mode, the ventilator computer basically runs Ohm's law of resistance many times per second in the background to compute how much resistance the endotracheal tube is adding to the pulmonary system. The ventilator then adjusts the circuit pressure to compensate for that added resistance. Notice that it increases the pressure above PEEP when the patient is inhaling, and it actually decreases the circuit pressure below PEEP when the patient is exhaling to make exhalation easier. You program this mode by telling it what size endotracheal tube or tracheostomy device the patient is using, so then it can do the calculations to compensate for that particular tube. This mode can be used on its own as a weaning mode, like it's drawn here, but it can also be added on top of any other ventilator mode on the advanced ventilators that support it. Finally, let's talk about a mode called mandatory minute ventilation. This mode has a baseline of pressure support breaths, that is, constant inspiratory pressure breaths that the patient starts and stops on their own. And then, just like in volume support mode, the inspiratory pressure is automatically adjusted to try to hit a target minute ventilation. The big difference here is that if the patient isn't achieving the target minute ventilation on their own, either because the inspiratory pressure can't get high enough, or because the patient's respiratory rate is too low, the ventilator adds in volume control breaths to assure the target mandatory minute ventilation is achieved. So in a way, you can think of this mode as similar to volume control SIMV with pressure support, except that the volume control breaths are only given if the patient won't hit the target minute ventilation. It's popular and has some data behind it in neonatal intensive care units especially because it's ready to respond to apneic periods without any delay. So that concludes our tour of advanced computer control ventilator modes. We looked at volume support, which is just like pressure support, except that it adjusts its own inspiratory pressure to hit a target tidal volume. We looked at proportional assist ventilation, which computes the appropriate circuit pressure changes to take on some set proportion of the patient's own work of breathing. We saw how automatic tube compensation calculates Ohm's law to compensate for the resistance added by the endotracheal tube or tracheostomy device. And we looked at mandatory minute ventilation, which is similar to volume support, but adds volume control breaths if the patient isn't getting their target minute ventilation. One last conceptual thought I want to leave you with is that there are three fundamental levels of complexity in ventilation modes. The standard conventional modes, like your basic pressure and volume assist and assist control modes, and pressure support and SIMV modes, do the same thing with every breath. That means they can't necessarily respond to every change in the patient's physiology, but they are very predictable. On the next level, you have your servo modes that watch one parameter to adjust another. These include pressure-regulated volume control, volume support, and mandatory minute ventilation. These modes are able to adjust to some changes in the patient's physiology, but you have to be very aware of what they're changing and why. For example, in pressure-regulated volume control, if the patient coughs during one breath's inspiratory period, the next breath will be delivered at a much higher pressure to try to make up for it, which might not be what you want. And finally, you have high-speed computer feedback modes, like proportional assist ventilation and automatic tube compensation. Because they rely on high-speed computer calculations, they can respond very precisely to physiology. But they also introduce more unpredictable error modes, especially if the patient's pulmonary pressures start oscillating in an unusual way. For example, I can't claim to know exactly what would happen if you had a patient on proportional assist ventilation and then started giving them aggressive percussive chest physical therapy, but based on the underlying computations, the ventilator might start increasing and decreasing the circuit pressure rapidly. So with that framework, we'll conclude our whirlwind tour of the ventilator modes. Next time, we'll get back into physiology by looking at hypoxemia and hypoventilation. Thanks for your attention. I'll see you next time.